Hello, good evening to everyone. Welcome to the day 3 of FCPI Virtual ID Week. And we successfully completed 2 days of FCPI sessions. Thank you for your participation. And my name is Dr. Saidulu Ganta. I'm practicing clinical pharmacist from Hinduja Hospital. And coming to the today theme of the session, challenging ID cases, how can it get more complicated? And we have eminent speakers from today's session. We have 3 speakers. And our first speaker is Dr. Parikshit Prayag. Thank you, sir, joining with us and accepting our invitation. And Dr. Parikshit is infectious diseases consultant at Dinanath Hospital, Pune. He's completed his MBBS from India. Then he's moved to his internal medicine PG and completed from St. Banaras Medical Center, New Jersey, USA. Subsequently, he did his infectious diseases specialization from MD Anderson Center. Then he completed his transplant fellow from Stanford University. Sir has several international and national presentations. Yeah. So, sir is a part of National Transplant ID Subcommittee of the Clinical Seats of India, and he's closely works with the ID clinical pharmacist when he was in USA, and now he has a clinical pharmacist in his team. And it's my honor to welcome you, sir. And over to you. Thank you, sir.
Yes, thank you so much, Saidulu. Thank you for inviting me. Can I start my session?
Yes, sir. You can share your slides.
You can see my slides?
Yes, sir.
Okay, yes. So good evening, everyone. And once again, thank you for the warm invitation. Firstly, I'm so happy that you guys are focusing on an ID pharmacist conference, because as I've always been saying, it's a concept that really needs to percolate across the country. And I know you guys are doing some great work there. So thank you for organizing this conference, and thank you once again for inviting me. So we have about 25 to 30 minutes, and the topic is some interesting cases in transplant ID. It's a vast topic to cover in 25 to 30 minutes. So I will probably be showing you some 5 to 6 representative cases, which sort of give us a perspective about what the world of transplant ID is. And, it just opens our mind up to the various possibilities that can exist, the various complications that can arise. So I thought we would start with some kind of a background about transplant ID. Now, when I use the word immunocompromised patient, it's a huge spectrum. So right from the mild immunodeficiency that is associated with pregnancy, up to someone who has undergone a transplant, or even further, I had failed that transplant, has undergone maybe a repeat bone marrow transplant. This is a huge spectrum of immunocompromised patients. So I always say that we shouldn't use the word immunocompromised. We should try and ascertain what the exact immunocompromising condition is. So if you look at immunocompromised patients, you can broadly divide them into those who have neutropenia, those who have B cell dysfunction, those who have T cell dysfunction, or those who have mixed defects. So if you look at the neutropenic patients, these are going to be my patients who have therapy-related neutropenia, or maybe patients who have AML. Now they are going to be predisposed to bacterial and fungal infections. So candida, molds. If you look at those who have B cell dysfunction, so patients who have undergone a splenectomy, or patients who have received drugs like rituximab, they would be so predisposed to certain organisms like PCP, or post-splenectomy, these would be encapsulated organisms. Now, T cell depletion is something that we very commonly see. So our solid organ transplant patients, or who are on T cell suppressive therapy, these are predisposed to intracellular pathogens, endemic mycosis. And then very often we in day-to-day practice, we see patients with mixed defects. So let's say a patient who has AML to begin with, and now has undergone a bone marrow transplant. So not only the neutrophil quality and function, but his T cell function is also a big problem. So that is what we very often see in real life. Now, coming specifically to solid organ transplant recipients, there are a number of factors because of which they have immune dysfunction. So the journey begins before the transplant. So the transplant is just a time point in his entire journey. But if you look at the underlying disease, so definitely something like CLD, which is associated with complement dysfunction, neutrophil dysfunction, T cell dysfunction. So CLD, CKD, or autoimmune disorders, because of which patients become a transplant candidate. All these could be immunosuppressive conditions. Then the actual transplant and the post-transplant factors. So induction immune suppression. A lot of programs use ATG or high-dose steroids. Then we have calcineurin inhibitors like tacrolimus, cyclosporin, antimetabolites, MMF and azathioprine. Then you have other immunosuppressants like sirolimus, everolimus, steroids. And then other factors, rejection. So for example, 1 year down the road, I think later on we have a case, a patient who received rituximab for his rejection. So again, these sort of factors can play into the risk factors for these patients. Then viruses like CMV. We have all seen how immunomodulatory COVID is. So CMV is similar. CMV patients can be predisposed to a number of other infections. So a number of reasons why these patients who have undergone solid organ transplants can be immunosuppressed. So that's why formulating a differential is a complex process. So you have to take into account several factors: his pre-transplant infectious history, social history, travel history. Then depending on the time point when you're seeing this patient, whether it's just after the transplant, then I'll consider his donor details very thoroughly, or his pre-transplant serologies. If it's later on, maybe 6 months, 12 months down the road after his transplant, then important details are, what is the kind of prophylaxis that he's on, whether he has been treated recently for rejection, what are his immunosuppressive therapies. And then, of course, the clinical syndrome, formulating a differential, and then working up these patients is very, very important. Lesser empiricism, the better in the world of transplant ID, because it becomes very difficult to, once you fall behind the game, it becomes very difficult to chase these patients. So your best time of getting all the information is upfront when you're working up these patients. So I think with this small introduction, we will look at 5 or 6 cases. So my first patient is a patient with liver transplant 4 months ago, who was on sirolimus. This is, I think, a case from last year, who was on sirolimus, mycophenolate, and prednisone. So if you look at his donor recipient sero status, he was donor positive, recipient negative, which is a very uncommon pattern in India. Most of our recipients are actually CMV seropositive. So this is one high risk category: donor positive and recipient negative as far as CMV is concerned. And the same thing for EBV: donor positive, recipient negative. Now he comes with a week of fever and cough, and he's on acyclovir prophylaxis at this point of time. Now, if you look at his CT scan is showing large nodular consolidations with some perinodular ground glassing. So if you look at this sort of a CT scan, obviously your differentials are going to be, fungal is going to be a very important differential. So if you look at various molds such as Aspergillus, now the CT is not very classic for mucor, but Aspergillus, mucor, fusarium, or other molds, pigmented molds, these are going to be important. Other things such as cryptococcus, we see more of cryptococcal pulmonary infections in our SOT patients than in our BMT patients. So cryptococcal disease, depending on the right kind of endemicity, other molds or endemic mycosis such as histoplasma. Then coming to the bacterial world, his other differentials are going to be something like nocardia, TB. These are going to be important differentials as well. And classic typical bacterial pathogens could be in the picture, although the CT is not very classic for something like a staph, strep, or Klebsiella. So with these differentials, like I said, the best time to get all the workup is upfront. So we actually did a bronchoalveolar lavage, and his serum galactomannan was 0.3, his bile galactomannan was 0.5, and his bile cultures grew Candida albicans. So again, this is a temptation that we need to avoid. Immunocompromised, a lot of Candida is unnecessarily treated under the guise of the patient being immunocompromised. So again, this is not a patient who clinico-radiographically looks like someone who has Candida pneumonia or pneumonitis. So again, this is a colonizer at this point of time. Blood cultures grew Staph hominis. So again, you have two different bugs there which don't fit into the clinical picture. It's 1/4 bottles, but your bile galactomannan as well as serum galactomannan is negative. So what could be the approach? Are we still considering Aspergillus? Are we considering non-Aspergillus molds? Are we considering the other bacterial pathogens? So what about galactomannan in solid organ transplant patients? So the galactomannan sensitivity in solid organs transplant patients is slightly lower than what you see in neutropenic patients or in BMT patients. So this is not a neutropenic patient. This is a patient who has undergone a liver transplant 4 months ago. So if you look at liver transplant data, then the sensitivity is slightly lower than hematological malignancies, neutropenia, and so on. The bile has slightly higher sensitivity, but again, it's not going to be anywhere close to what you would ideally want it to be in this kind of a setting. There is emerging data on aspergillus PCR, both serum as well as BAL. There is more data again in the neutropenic setting where the sensitivity is higher. And again, BAL aspergillus PCRs could indicate colonization as well. So these are the kind of things that we need to distinguish between. So lung biopsy was done. So lung biopsy is a useful test in these type of radiographic pictures, wherein we are still contemplating molds. The other important differential here could be something like EBV related PTLD, because he was EBV donor positive, recipient negative. He has a large consolidated lesion, which is a mass-like lesion. So, that's why with all these differentials, and because of the fact that BAL didn't give us much, we did a lung biopsy, and we did a aspergillus PCR on the lung biopsy, and this PCR was positive. So it's saying that it is positive for aspergillus species, but it's negative for flavus, tereus, and fumigatus, which means that apart from these three, flavus, fumigatus, and tereus, there is some other species which is being detected. So maybe something like lentulus, something like calidostus. So again, these decisions are going to weigh when I look at what sort of therapy I'm going to start him on. Again, most liver transplant teams are worried about the hepatotoxicity of azoles, even liposomal amphotericin B. So he was started on isavuconazole, and then a few days later, his isavuconazole levels were 1.6. So this is since large part of our audience is our pharmacists. I'm focusing on some of the pharmacological details for these drugs. So isavuconazole levels were 1.6. So very important question or a take-home message from this case is, one is that you need to weigh the sensitivities, you need to weigh the pre-test probabilities for each test that you perform in that particular setting. So when I'm trying to analyze galactomannan, I'm trying to analyze the performance of galactomannan in the setting of a solid organ transplant. The second thing here is, do we need to obtain isavuconazole levels on all our patients? Now, because we did the levels, we found that these levels were slightly subtherapeutic. This is something that we recently published. So in about 50 odd patients whom we studied in our setup, 5 out of these patients had subtherapeutic levels, which means level less than 2. But a number of patients actually had their isavuconazole doses changed after doing the levels. So, again, it all depends on what kind of pharmacodynamic targets that you are using for these patients. So again, if I'm treating something, so as I showed you, this is a species which is not flavus or fumigatus or tereus. So, species such as calidostus, lentulus, I need to be careful with their azole MICs, and then my chances of curing this type of a patient with a level of 1.6 are not that great, because if I had to roughly estimate, then 1.6, the area under the curve would roughly be, something like 24 into 1.6 plus 10, which is roughly around 50 is going to be my AUC here. Around 40 to 50 is going to be my AUC if I had to just, make a wild guess. Now, with the MICs that I have for these species, it may be slightly difficult to, cure this type of a patient. So again, you have to look at the kind of settings in which you are getting the levels done. So isavuconazole dose was increased. In fact, in our study, we found that solid organ transplant patients did seem to have subtherapeutic levels. The effect wasn't maintained on multivariate analysis, but on our univariate analysis, the solid organ transplant patients did have subtherapeutic levels more than, the other groups of patients. So after 6 weeks of therapy, he had complete clinical and radiographic improvement. Of course, tacrolimus levels were monitored. Wouldn't be as much of a concern as with fluconazole or Vori or posaconazole, but we still definitely need to monitor tacrolimus levels in the setting of isavuconazole. We will switch the type of transplant. So we'll go over to a BMT case now. So this was a 42-year-old gentleman with FLT3 positive AML who was status post his induction chemo. And then he underwent a transplant. And then, after his transplant, actually, he comes to us with diarrhea, nausea, vomiting. I think I'll skip to this part. So he undergoes a transplant, and 3 months down the road, he comes to us with diarrhea. And his PCR panel is showing a C. diff, which is positive. So he gets started on oral vancomycin. His diarrhea initially improves, worsens again, becomes bloody. And then vancomycin is changed to oral teicoplanin, and endoscopy is recommended. So his posaconazole levels at this point of time are 373. So he's been on prophylactic therapy because he was also getting steroids as a part of GVHD. Initially, they had suspected GI GVHD. So his serum galactomannan and beta-D-glucan levels were negative. Stool ONP was negative. And then this was the endoscopic picture that we got. So if you look at the gastric body, and if you look at, his duodenal region, more so in the antral region, you have large necrotic masses. So when you see these type of masses, again, molds are very high on your differentials. Now, the biopsy findings were actually broad aseptate hyphae, suggestive of mucormycosis. But a very interesting thing was that his cultures which grew on Maldi, the species was identified as Mucor circinuloides. Now it's a species which is particularly associated with very high resistance as far as the azoles are concerned. So amphotericin and posaconazole, if you compare across the various subspecies and the various genera for mucormycosis, then Mucor circinuloides is something which can be associated with very high MICs for azoles. So again, the same point here that when you are considering these patients, look at the species, subspecies. So this is a patient whom I would find it very difficult to de-escalate to something like posaconazole. Even isavuconazole is going to be poor when it comes to Mucor circinuloides. If you look at the relative MICs for each of these species here, you will see that posaconazole as well as isavuconazole both are poor options for Mucor circinuloides. Unlike, for genera like Listhymia, these could be great options. But again, this is a patient that we had to treat with liposomal amphotericin. Now, unfortunately, as with a lot of GI mucormycosis, the outcome wasn't great. So he was started on 7.5 milligrams per kg of liposomal amphotericin. He rapidly developed septic shock. In fact, he turned out to have carbapenem resistant Klebsiella as well. And then he had worsening shock and ultimately succumbed. But again, a case that puts into perspective the choice of therapy based on species. So next we have a 40-year-old male who has undergone a living donor renal transplant in June of 2021. In October, he developed evidence of FSGS on biopsy. So he received rituximab. In March, he had COVID pneumonitis, and now he presented with fever and cough. And then he was on tacrolimus, MMF, and 10 milligrams of prednisone per day. His creatinine, his new baseline was around 3. So remember, he found this evidence of FSGS on his biopsy for which he had received rituximab. So his new baseline was around 3. Now, this is the kind of radiographic picture that he comes with. Again, when I look at this picture, I'm worried about similar differentials that we went through in the first case. So I'm worried about molds. I'm worried about TB, maybe PTLD in the right kind of setting, cryptococcus, other fungal infections. So his bile cultures actually grew nocardia. So now his MRI brain is within normal limits. So how will you construct a regimen for this patient? So again, if you look at this, again, as I mentioned, the best time to get all the workup is upfront. So definitely I want to know the extent of involvement. So I want to know, because he's an immunocompromised patient, I want to know whether this nocardia is disseminated. So I want to know the CNS involvement, cutaneous involvement, the extent of his pulmonary involvement, how sick he is. So whether it is severe pulmonary nocardiosis or can I call him a mild to moderate pulmonary nocardiosis. So we didn't find any evidence of dissemination. So he had no skin lesions. The MRI brain was normal. The next very important thing that I want to know is which species of nocardia is it? Because again, in constructing the regimen, it's going to help me when it comes to choosing the regimen. So if I have a severe disseminated nocardiosis, then I want to use more drugs upfront. So again, isolated cutaneous nocardia or very mild pulmonary nocardia, you're okay using one agent. If you have like severe pulmonary or if you have disseminated, then you want to use 2 to 3 agents, especially if you have immunocompromised patients who have disseminated as well as CNS involvement, and it's looking like a fulminant picture. Even 3 agents upfront is justified. So initially, he was around about 4 to 6 liters of oxygen. So initially we had started him on PMP SMX plus imipenem. Now he had nocardia farcinica, but to our surprise, imipenem resistance is not very common in this species, but he turned out to have imipenem resistant nocardia farcinica. So again, this case highlights the complexities of choosing a regimen in transplant patients, because look at the options that I have there. I have amikacin, I have TMP SMX, and then I have linezolid, and then I have intermediate susceptibility for a few other drugs such as minocycline, tigecycline, doxycycline. Now, let's say he had severe pulmonary nocardiosis or disseminated, wherein I want to use 1 to 2 IV agents upfront. My options are very, very limited. This is a patient who is a post-renal transplant patient, post-renal transplant evidence of FSGS, received rituximab. So amikacin isn't the best option in this type of a patient. Again, I would be worried about giving him amikacin because these patients are going to need long durations of therapy. Linezolid can be an option, but again, we want to make sure that he's going to tolerate linezolid as far as his counts are concerned. TMP SMX also is going to probably cause a spurious rise in creatinine and is going to make our renal transplant team uncomfortable. So there are various constraints when it comes to transplant patients. So initially, we had started on TMP SMX plus imipenem. We stopped imipenem by the time we saw this report, and we have accepted some rise in creatinine. So his creatinine, in fact, he had just come to our OPD today for follow up, and his new creatinine is now around 4. But clinically, he's doing far better. So currently, he's on monotherapy. So again, we have a BMT patient up next. So he is a patient with AML, post haploidentical stem cell transplant. 3 months later, he develops grade 3 GVHD. He started on posaconazole prophylaxis and he's on ruxolitinib. 3 weeks later, he comes with cough for 1 week and low grade fever. And his CT chest is now showing a thick walled cavitary lesion in the right upper lobe. He undergoes the BAL. The BAL gene expert says that MTB detected low, galactomannan is 3.8 in the BAL, and serum galactomannan is 1.9. So now again, this is the case which makes us appreciate the complexity of transplant ID, because there are so many factors that I need to consider while constructing a regimen for this patient. So the first and foremost thing is that which are the organisms that I'm treating. So I'm treating an Aspergillus, I'm treating Mycobacterium tuberculosis. So difficult to ignore, although the burden, the load is low, but it's difficult to ignore, especially with this type of a clinical radiographic picture. Now he is someone who has GVHD. He is already on posaconazole prophylaxis. So has he broken through on posaconazole? Does he have subtherapeutic levels, or does he have truly breakthrough with a resistant species? Again, I have to balance the interactions here. So what am I going to change him to? So many different things. So let's say if I do drug levels of posa, and if they are subtherapeutic, then the question is that what are the likely reasons, because of which the drug levels are subtherapeutic? Is he someone who is having diarrhea? Is he obese? Is he on proton pump inhibitors? Because you have fewer factors now associated with the DR tablets than we did when we were using the oral suspension about 3 to 4 years ago. So if he has subtherapeutic POSA levels, what are the likely reasons? Is it interactions? Are there other drugs? Now, if the drug levels are okay and truly I am considering a breakthrough infection, then I would be worried about the species. So which species is it? Is it something that has high MICs for posaconazole? So now if I decide that, I cannot just increase this dose of posa and get away, then my choice of therapy basically is going to be voriconazole, isavuconazole, and amphotericin. These are the 3 drugs that I would have, because as we now all know that Vori, ISA, and POSA have shown comparable efficacy across various studies when it comes to treating invasive pulmonary aspergillosis. But usually, voriconazole and isavuconazole MICs will overlap. So which means that Vori resistant isolates will also be ISA resistant. So I here my choice is one out of these 3: voriconazole, isavuconazole, and amphotericin. If I choose something like Vori, again, I have to be mindful of interactions because he's on ruxolitinib. The other factor here, which is very important, is that he also has MTB, which is detected. So which means that what am I comfortable with? Am I comfortable with using amphotericin and giving him rifampicin, or I am ready to trade off this, because so I'm ready to let go of the rifampicin and switch to an azole. But remember, he has already failed one azole. So these are very complex decisions. So again, we have to, at this point of time, clinically, radiographically determine which is our bigger enemy here. Is it, what are his chances? If we exclude RIF from the regimen, the kind of regimen that we are giving for TB, is that better, or including RIF and using something like amphotericin? So again, we actually put him on isavuconazole. So these are the kind of isolates for which MICs would be important. Unfortunately, this didn't grow. So his diagnosis just remained as probable invasive pulmonary aspergillosis because it was based on galactomannan levels. So we chose isavuconazole, and then most of our TB plus mold infections in the setting of BMT, we have been using non-rifampicin containing regimens, and the evidence, the experience has been decent so far. But it just highlights, the kind of complexities. I think this is my last case. So this is a 40-year-old male with AML, again post haploidentical stem cell transplant on prednisone, which was being tapered. Now he presented with fever for 3 days, loose stools for three days. The stool C. diff assay was negative, slight leukopenia there, slight thrombocytopenia. Now his BDG was 234. Now he had presented with fever and diarrhea. His blood cultures are growing yeast. Now his species is identified as Candida auris by Malditov. Now he started on micafungin. His eye exam is within normal limits. Remember, he is not neutropenic at this point of time. So his eye exam is within normal limits. His transthoracic echo is not showing anything. He had a line which was inserted even before the bone marrow transplant. So that was removed. Now his broth microdilution panel is done, and you will see that there is some discrepancy across the echinocandins. Now, for the lack of time, I'll skip this discussion, but I would be happy to address it in the Q&A session. But there was some discrepancy within the echinocandins. Now, flu cytosine, the MIC is 0.25, which is actually a pleasant surprise because a lot of our ORS isolates, we actually have very high MICs for flu cytosine. And amphotericin was resistant. So he was started on micafungin. Now, on micafungin, his cultures on day 4 are still growing Candida auris in blood. At this point of time, a transesophageal echo was done. And then we did a CT abdomen pelvis. Why? Because that's one of the sites where micafungin would have very poor penetration, the genitourinary system. So his CT abdomen and pelvis was showing some enhancing areas in both the kidneys, suggestive of pyelonephritis with possible developing abscesses. And urine culture subsequently also grew Candida auris. So this was a disseminated Candida auris, although it's somewhat odd to have primary urinary involvement with Candida auris. So again, if you look at the genitourinary penetration of different echinocandins, then percentage drug in the urine is the lowest for anidula. Then you have micafungin, and then you have caspofungin. However, looking at the very low MICs, using high dose micafungin, there is some anecdotal evidence which suggests that for these type of situations, we can use high dose micafungin. So actually, we added flucytosine and then increased his micafungin to 200 milligrams daily. With Candida auris, duration of therapy is something that we need to consider. There is some increasing, I wouldn't say evidence, but school of thought that longer durations of therapy are recommended. Something like 3 weeks for our Candida auris isolate. So again, this is a case which highlights the site of infection. So depending on where your site of infection is, again the choice of therapy is important. So I think I'll stop here. So looking at all these cases, transplant infections, it definitely, these infections need a multidisciplinary approach. Apart from a multidisciplinary approach, we also need to consider various factors. So if they are breakthrough, if they have been on prophylactic therapy, if this is a breakthrough, then where is the site of infection? And from a pharmacist point of view, also transplant ID is pretty complex because you need to go through the various interactions. You need to go through the PK/PD of each drug. And again, for each of these infections, local pharmacodynamics is very important. So I want to achieve my pharmacodynamic target at the site where the infection is, not just in the blood. So let's say I'm treating a CNS or a pulmonary infection. I want to make sure that my pharmacodynamic targets locally are also achieved. So I think this is again a very important area where the role of a transplant ID pharmacist, is very, very critical. So I think I'll stop here. We have about 10 minutes for the question and answers. And again, thank you for having me. Look forward to the discussion.
Thank you, sir. Very informative and very challenging case. Maybe that will be very useful for ID clinical pharmacist. And we have some couple of questions for you. So is there any PK/PD targets are different cancer or neutropenic patients compared to the other regular patients of antimicrobials, PK/PD targets?
So the PK/PD targets, rather than the host, what happens in the immunocompromised patients is that you have various drugs which can interact with these agents. So again, there, we have to factor these in, and we don't have access to all the drug levels, right? So if we can have access to azole levels, but for a lot of the other drugs, we don't have access to the drug levels. So then it can be a challenging subject. And as I mentioned, the local pharmacodynamics is also very, very important in these patients. So what makes PK/PD challenging in transplant patients is interactions with a number of other drugs. Also, the fact that these patients could have 2 or 3 infections at the same time. We see patients with multiple infections at the same time, just like the one I showed you, TB plus mold infection,
Yes,
which is very rare in immunocompetent patient. I would hardly see an immunocompetent patient who is coming to me with a mold and with a pulmonary TB and with CMV at the same time. So again, end-stage HIV transplant patients, these are the kind of patients in whom we get 2, 3, 4 infections at the same time. So I think balancing all these things, balancing the interactions and balancing the local pharmacodynamics, that becomes challenging, especially when we don't have access to some of the levels. So at least azoles, we have access to drug levels, but how many of the important drugs that we use in our clinical practice, we have access to the levels? I think, so there must be a continuous effort also to establish these levels to get a good sense of the pharmacodynamics.
So the second question, any role of nebulized amikacin in nocardia treatment? Like you discussed one case that is sensitive to amikacin, like any experience with nebulized amikacin for nocardia?
So, it is unusual for nocardia to cause a pure tracheobronchitis. Usually, when I have nocardia, I would expect it to cause an invasive pulmonary disease. Now, so that's why adding inhaled therapy on top of IV therapy, the benefit is very, very questionable. When we look at our patients, who have, let's say, who are on ventilators and, who have thick secretions, leukocytosis, fever, but don't have the classic signs or criteria for VAP, and we are labeling them as tracheobronchitis, and then they have something like pseudomonas or gram negatives, I think that is a good indication for inhaled therapy. Again, outside nocardia, whether inhalational therapy adds anything to IV therapy is questionable. I mean, the evidence is very mixed. So I personally don't use IV and inhalational therapy together.
Okay, sir. Like where we can use high dose of like echinocandins other than like Candida utiatic micafungin, where we can use high dose of echinocandins.
So, I mean, Candida endocarditis is one good indication to use high dose of echinocandins. Again, these, as I mentioned, apart from endocarditis, the site of infection is important. So, if I'm trying to take care of an infection in a site where echinocandin penetration is poor, that's something that needs to be considered. As I said, genitourinary candidiasis. The other things, depends on the MICs. Although even with auris, usually for our mica fungin and anidula fungin, MICs is not something that we struggle with. So refractory cases or recurrence of candidemia on therapy or unusual sites of infections or endocarditis, these would be the conditions in which I would think of high dose echinocandins. And auris, again, is something that I would probably prefer using high dose echinocandins. So certain species as well, definitely.
And do you think like the role of ticoplanin for C. diff management?
So if you look at literature, the literature is sparse because a large reason why the literature is sparse is that they don't have ticoplanin in the US. So there is not much coming from there in terms of literature. Now, about 4 years ago, we started using oral ticoplanin for our refractory cases, vancomycin refractory cases. The first couple of years, I would say the experience was very, very good. But lately, I have found in the last 6 months to 12 months that a lot of our vanco refractory patients have also remained Tico refractory. So in fact, almost 30 out of these patients, we have had to perform a fecal microbiota transplant or an FMT. So my experience with oral ticoplanin hasn't been as encouraging lately as it was when we started out. Now, a large part of this is that there are many unknowns when it comes to the mechanism of resistance for C. diff when it comes to vancomycin and ticoplanin. Now, it's not as well established as the resistance mechanisms in Staph aureus or in Enterococcus. So I think there is still a fair way to go. Definitely, we would like randomized studies comparing vancomycin versus ticoplanin. I mean, that's something that we've been planning to do for a long time. Unfortunately, it becomes difficult to study these prospectively and wait for failure to wait for failure of therapy and then switch over. So logistically, we've had some issues in doing this kind of a study in our setting at least. But this could be a great study in the Indian setting, looking at the efficacy of oral ticoplanin for our C. diff patients.
Then like how you treat, so the patient have like uncomplicated GNV bacterium in neutropenic sepsis, what's your duration of therapy? Like current guidelines says that short is better kind of thing. Like, so can we applicable those things in post-transplant patient with neutropenic sepsis with GNV bacteriemia?
So I would be very cautious, treating neutropenic patients with shorter durations of therapy. The large studies which have looked into this, they have mostly not had a good representation of immunocompromised patients. For my neutropenic patients, usually I don't treat with short durations of therapy as far as GNV bacteremia is concerned.
Okay. Like what is your dosing, sir? Like most of the neutropenic sepsis patient, they have initially like low creatine, augment renal clearance. So you with the high dose of like meropenem 2 gram TID, like kind of thing, like still you are giving the standard doses. You still believe that ARCs exist in neutropenic sepsis patient? What's your practice, sir?
Yeah, so one utility of these high doses is prolonged infusions. Even if you look at the latest IDSA recommendations, which have come out, in fact, just this week for gram-negative, the guidance document for gram-negative infections, then they have stressed on the importance of, you accept uncomplicated cystitis. They have stressed on the importance of using high-dose prolonged infusions of meropenem, even for our ESBL isolates, and definitely when you're using it for the carbapenem resistant isolates as combination therapy, or when you have higher MICs. So as far as possible for these type of patients, I prefer using high dose prolonged infusions.
Okay. So, sir, when to cover like gram-positive or neutropenic sepsis or neutropenic patients, when you add that teicoplanin, vancomycin, rinezolid, like what situations we can consider?
So it's not a drug that we use upfront in neutropenic fever or febrile neutropenia, unless you really have a good clinical reason. So for example, if you have a patient in whom you're suspecting a line-related infection, or if you have a skin and soft tissue infection, or let's say this is a hospital-acquired pneumonia, depending on the incidence of MRSA in your setting. So these are the kind of indications. So usually, using vancomycin and teicoplanin upfront is not something that is recommended. Again, we have to remember that when we are giving these patients drugs like cefepime, or when we are giving these patients meropenem or imipenem, we are giving them decent gram-positive coverage. We shouldn't look at carbapenems as exclusive gram-negative drugs. We are still covering strep, we are still covering MSSA, we are still covering to a certain extent, ampicillin susceptible enterococcus. So these are bugs that we are still covering, especially the drug like imipenem has decent gram-positive activity. So it's for MRSA, or maybe for your ampicillin resistant enterococcus that you would need teicoplanin. So you should really select out patients carefully. So septic shock, patient has a line there, is neutropenic, or someone who has a skin and soft tissue infection. These are the kind of patients in whom I would prefer using teicoplanin or vancomycin, but it shouldn't be a blanket therapy for everyone with febrile neutropenia.
Okay, sir. Plain neutropenic or post-transplant patient, like he has like Candida growth in urine. Shall we treat, or like can we leave it as a colonizer? It's always indicated for treatment.
Yes, so neutropenic patients who have Candida colonization in the urine, neutropenia would be an indication to treat that. Now that's easier said than done, because a lot of times now we have colonization with fluconazole resistant species. So there, you are left with drugs like flucytosine or amphotericin to treat when it comes to neutropenia. When it comes to the post-transplant setting, the benefit is slightly questionable. This is a debatable issue, whether asymptomatic candiduria should be treated post-transplant. In the initial stages, in the immediate post-transplant period, at least there is some evidence to treat it. But in the delayed post-transplant period, definitely beyond 3 months, there is not much evidence to treat asymptomatic Candida colonization.
Okay. That is the questions we have, sir. Thank you so much for joining with us. Thank you, sir. Just a minute, I'm sharing my slides. Good evening, sir. Good evening. Today, our second speaker, Dr. Neeraj Siddharthan. Sir is a professor and head of Department of Clinical Hematology Division of Stem Cell Transplant at Amrita Institute of Medical Sciences, Kochi, Kerala, India. After completing his medical degree, Sir did his specialization in bone marrow transplant and flow cytometry, clinical flow cytometry from CMC Medical College in Vellore. Sir has 25 publications in international and national journals. And like for his excellence works during his post-graduation, he received Professor T.K. Raman Gold Medal Award from University of Kerala. And for his utmost patient care, he awarded in Patient Support Organization Hemophilia Federation of India, Kerala chapter, for his contribution to the hemophilia patient care. Thank you, sir, joining with us. Thank you, sir, accepting our invitation. And we request to the participant, if you have any questions, share in the chat box and fill the feedback form. You get for certificate. You can go ahead, sir. Thank you, sir.
Thank you.
Can you share your slides, sir?
Yeah.
Yes, sir. Your slides are visible.
Visible?
Yes, sir.
I'm
Yeah, yes, sir.
audible also? Okay.
Yes, sir.
Thank you. So, first of all, my sincere thanks for having me here in this FCPI virtual ID meeting. And it was a pleasure to listen to the previous speakers' talk on the transplant cases, the challenging ID scenarios. So I have a disclosure that I'm a hematologist. So I would be, presenting the perspective of a hematology patient, so from the view of a hematologist rather than an ID physician. So please bear with me for that. So I thought, when Vrinda had asked me to do this, so I was just thinking about the significance of this topic, which we see day to day in patients undergoing treatment with us, both hematological and oncological diseases. So basically, as you can already see, they have an immune system which is compromised, and they have at a higher risk of developing rarer and also severe infections. So the other things is that, the infections, once they happen, that leads to treatment delays, treatment interruptions, dose reductions, and ultimately may result in a poorer outcome for the patient in terms of mortality as well as morbidity. So, yeah. So essentially, in hematology, this slide is borrowed from Twitter, but I kind of very much like this slide because this sums up the majority of the ID problems that we see in hematology. So febrile neutropenia is considered a medical emergency, and it is defined as that you have a fever, and it is defined as you have 100.5 for more than 1 hour, that is 38 degrees Celsius, or if you have a one value of 38.3 degrees Celsius. And again, here it is important that the rectal temperatures are not measured. And in combination with this fever, you have a host immune system, which is having neutrophils less than 500. There is also another category of severe neutropenia, which we say ANC almost 0, or rather defined as less than 100. So when you calculate the neutropenia, it is neutrophils plus the band forms that we calculate. So in this context, you may have any of these three, the bacterial, fungal, or viral infections. So the most devastating bacterial infections that we see are the gram-negative, and sometimes you may have a gram-positive anaerobic, or the previous case described of tuberculosis also could be there. And fungal, of course, candidemia is one of the common fungal infections that we see. The other is aspergillus. And viral, most common would be herpes, and then you would also see other viral infections like Epstein-Barr viral infections and cytomegaloviral infections, etc. Sometimes, especially in post-transplant setting, you may see other lethal viral infections like adenovirus. The other respiratory viruses like rhino and corona are less commonly seen in our setting. So we face some unique challenges because some of the symptoms of infections may be very non-specific. For sometimes they may present without fever. So even for the neutropenic sepsis, sometimes you don't have a fever, but still the patient may have any symptom, like any new onset symptom like abdominal pain, vomiting, tiredness, or loose motion. So this classic definition of febrile neutropenia may not apply to a neutropenic sepsis. So right from the beginning, our diagnosis is itself in difficulty. And then it can be the other way around also. You may have a lymphoma or a leukemia presenting with fever, and the patient may be neutropenic, and the fever may not be a neutropenic fever. It may be due to the underlying disease. So both ways that there is diagnostic difficulties. The second problem that we face is, the choice of the medicines that or the antimicrobial agents, which Dr. Parikshit was carefully referring to. So, you have to choose it in such a way that you have a good efficacy, and you have to balance the toxicities and drug interactions, especially when the patients are on other drugs, and some of the patients may have a compromised organ function. And to add to this, in the current era, we have antibiotic-resistant pathogens, especially gram-negative bacilli, which are multi-drug resistant. And so that again sort of complicates the management of infections in this population. So it is very important that in hematology patients with neutropenia, you have to learn to tailor the treatment regimen to target the specific pathogens that you have in mind. Now, in addition to the regular pathogens that you see, you also see a lot of opportunistic infections like Aspergillus, pneumocystis, varicella zoster, cytomegalovirus, etc. So while some of these infections you do prophylaxis, in some you have to early treat or preemptively treat. So I think the most common infections would be the bacterial, which include the gram-negative bacteria, which like E. coli, Klebsiella, Pseudomonas, and Acinetobacter are the common bacteria that we see. And the infections can involve various sites like gut, respiratory tract. Mostly it is the gut, but respiratory tract, urinary tract, or skin and soft tissues are seen. Fungal infections are basically, you have opportunistic candida, usually involving the bloodstream, which is most commonly seen in the hematology patients. And Aspergillus, usually the most common site, as you can see in this figure, is the lung. In addition, you could also have a mucormycosis, which usually is a sinonasal infection. So in general, candida is bloodstream, Aspergillus generally in the lung. Mucor also can be seen in the lung, but mostly it is a sinonasal infection that we see. The viral infections, as mentioned earlier, it can be sometimes visible like a herpes simplex that you can see, or it can be varicella zoster. Sometimes the viral infections is not visible, like a cytomegalovirus may present just with fever, and Epstein-Barr virus may present with a lymphadenopathy. A parvovirus may affect the bone marrow, and the patient may present with a transfusion requiring anemia. And then, of course, you have the other respiratory viral infections. The parasitic infections like malaria, toxoplasmosis, and strongyloiditis, although they are less common, also have to be kept in mind. So the first case is a 58-year-old male who was diagnosed with acute myeloid leukemia and was started on induction chemotherapy with cytosine and daunorubicin. And on day 10 of his therapy, he developed a fever with rigors and elevated inflammatory markers, and there was no obvious focus of infection. Blood cultures were obtained and empirical broad spectrum antibiotics were initiated. So the blood culture grew a Klebsiella pneumonia, and it was found to be ESBL positive. It was an MDR. And so in a few days' time, although initially there was no evidence of any focus, in a few days' time, he had an evidence of colitis, and especially on the right iliac fossa, he had tenderness, and a CT scan showed that he had a typhlitis. So here, we have a ESBL producing Klebsiella, and it is an antibiotic resistant. So we know that the traditional antibiotics will not be of benefit. And now this is of a gut origin. And sometimes mostly what we see is, perianal infection. So for this patient, it was typhlitis, but for many patients for AML infections, what we see is perianal infections, and there will be perineal abscesses. So sometimes this can lead to, a need of surgical intervention, but in neutropenia, that is one more challenge. You cannot straight away go for a surgical intervention. So here we had done analysis of the surveillance of stool culture, which we generally do for our patients with hematological malignancies undergoing high-dose chemotherapy, like for acute myeloid leukemia. As you can see, almost everybody has an ESBL positivity, and there is a significant percentage of patients having carbapenem resistance. So this is indeed very alarming. And initially, we used to have difficulties in getting the right antibiotics across, because when you have to treat, you have to decide whether you have to start with the piptas or whether you have to start with the carbapenem, or whether we should give polymyxin or ceftazidime-avibactam. Now, you need to also enforce infection control measures, including isolation of the patient, adherence to hand hygiene, and environmental cleaning. So the other important thing is to have a close collaboration between infectious disease team and the oncology team, and so that we have, inappropriate antibiotic use decreased, and so that we, prevent the emergence of further antibiotic resistance. So what do we generally use for empirical neutropenic gram-negative bacterial cover? So in our algorithm, for a patient who is having neutropenia around 500 or less than 500, and the patient is clinically stable, we would start with piperazolone tazobactam. And then if the patient is still spiking fever after a day or two, then we would escalate to carbapenem. If the neutrophil count is less than 100, and that means almost zero neutrophil, then we would often start with carbapenem, because we are likely to deal with, there is at least a 50% chance now that we are likely to deal with a carbapenem resistant ESBL, or almost 100% we are sure that it's going to be ESBL in a GNB in a neutropenic patients, and a 50% chance that you may be dealing with a carbapenem resistant bug. So we anyway start with the carbapenem and have a low threshold of elevation to ceftazidime, avibactam, and aztreonam. So if the patient is clinically unstable, having hypotension or hypoxia, then the antibiotic would be ceftazidime, avibactam plus aztreonam combination. So it's very simple now, the 3-tier of antibiotics for a GNB cover. Now, the next case is a patient with non-Hodgkin lymphoma, a 45-year-old lady, and during the course of her treatment, she developed painful vesicular lesions on her lip and complained of flu-like symptoms. So this is a simple case. There's nothing complex with it, but this is something which we could have been avoided, because this is a herpes simplex infection. It is important that in many chemotherapies, we establish protocol for preventive measures. So this patient was not on azacitidine or valacyclovir prophylaxis. So now for most of the hematological malignancies, while they are on treatment, we prophylax with azacitidine or valacyclovir. And this patient was particularly treated with this as well. So moving on to the third case, this is a 28-year-old male who was undergoing treatment for refractory Hodgkin's lymphoma. So he underwent an allogenic hematopoietic stem cell transplant as part of his treatment. And during the neutropenic period after the transplant, he developed a fever and showed signs of sepsis. So blood cultures were obtained and they grew Candida species. So he grew actually non-albicans Candida. It was a Candida tropicalis, and that confirmed the diagnosis. Here what has happened was that the patient was hemodynamically stable, and he had only a single catheter, and this was a PICC line. And so the patient had grown Candida from the PICC line and also from the peripheral line. So now it is a matter of debate whether in a neutropenic patient, whether we should remove the catheter or not, because Candida is also a very lethal infection, and you should immediately start with the sensitive antibiotic. Here the patient had started on echinocandins, and then he was started on caspofungin actually. But here we consulted the ID physicians from our setting, and carefully a decision was made to keep the catheter here. So in candidemia, I think one of the important things is that the initiation of antifungal therapy should be very prompt. Mostly we go with echinocandins as the first-line treatment of candidemia in a neutropenic patients. You could use caspofungin, micafungin, or anidulafungin. Now, how do we decide on whether to keep the catheter or remove it? See, what we consider the factors like clinical stability, the likelihood of a catheter-associated infection, and the ability to achieve a source control. So in our case, we kept the catheter with the appropriate antifungal therapy, and we gave a close monitoring, and then till the patient recovered from the neutropenia. So, and if you have a source of candidemia, like if you, and then it is important, like one of our cases, we had a candidial endocarditis in a patient with leukemia undergoing induction therapy. So once the neutropenia had settled, in fact, we had to do a surgical excision of the vegetation. So in a candida endocarditis, that is the source control measure. So appropriate source control measure is very important in candidemia. So in the case that I'm mentioning, there was no endocarditis, so we just treated with the echinocandins. And so the other thing is the supportive care. So now, what are the supportive care? In general, we would give the fluid balance, hemodynamic support, etc. But one thing I wanted to additionally add, both in the GNB sepsis as well as fungal sepsis in a patient with severe neutrophils with neutropenia with zero neutrophils, is granulocyte therapy. Although the evidence on granulocyte therapy has been mixed bag, but in our institute and in our department, we use it for severely neutropenic patients who are on optimal pharmacologic therapy and still having clinical instability or persisting fever. So granulocyte transfusion is something which I wanted to touch upon. So also would like to share basically one of the quality improvement initiatives that we did. This Merlin, our ID physician, has published this initiative. This is a very important quality improvement work done primarily by the clinical pharmacy team in ID and hematology departments to implement a comprehensive candidemia care bundle. So we collected the data in the pre-implementation phase and also in the post-implementation phase of this stewardship program, and try to look at the outcomes in candidemia. So this is not only limited to hematology and oncology cases, but there were also cases from other departments also. But primarily, we took the lead in doing this study. So, if you look at it, we looked at the provisional blood culture report, and then the mean time to start of antifungal before the implementation of this stewardship program was 57 hours. And after the implementation, the mean time to initiation of antifungal was around 12 hours. Now, so then what happens is that the primary team initiates in the pre-implementation phase, and then our team actually retrospectively audited the appropriateness. And in the pre-implementation phase, we found that appropriateness was around 29%. In the post-implementation phase, so what happens is why the mean time was shortened is because the clinical pharmacists, once we know the blood culture, we made the microbiology department alert the clinical pharmacist in the antifungal stewardship team. And once the clinical pharmacist was alerted, then there was a filling of the candidemia bundle checklist by the AFS clinical pharmacist. And then the AFS clinical pharmacist would inform the primary care team and then make sure that the antifungals are initiated for the patient. And then the patient case will be discussed in the weekly AFS meeting to assess the appropriateness of the therapy. And then, so what happened is that the appropriateness of therapy now increased from 29% to 60% in the post-implementation phase. So these were the numbers. If you want to look at it, the pre-implementation phase was from January 14 to 2015, and post-implementation phase was from October 2017 to December 2019. So these were the number of cases, 103 and 78. They were almost similar characteristics. In the post-implementation phase, we had more percentage of surgical cases. And if you look at the fungal species, they were spread all over here. In fact, in the post-implementation phase, we had a tougher phase, actually, because we had more Candida auris. We had an outbreak of Candida auris during the post-implementation phase. So it is more challenging in that phase. So basically, in-hospital acquired was 60% in the pre and 80% in the post-implementation phase. The CLABSI, which was more in the post-implementation phase. And if you look at the ICU stay, the use of central venous catheter, use of ventilator, the malignancy cases, and the neutropenic cases, they were similar in both the cohorts. Now, while in the pre-implementation phase, the empirical therapy was only 30%, in the post-implementation phase, it is significantly rose to about 94%. The antifungal resistance pattern also, we found it significantly less in the amphotericin and fluconazole and amphotericin. Most of these were sensitive to echinocandins. Now, the appropriateness of the antifungal treatment, as mentioned earlier, had shot up in the post-implementation phase. And if you look at the delay in treatment, this is one of the things that we had particularly looked at, the delay in treatment, right after the blood culture positivity, when do you actually appropriately start the treatment? So that was significantly cut down in the post-implementation phase. So, so this is what we tried to look at between the different bundles of the candidemia and in percentage in the patients who were alive and who had died. And it was the most of the compliance was there for antifungal selection and the appropriate dose of antifungal. The removal of central venous catheter was also complied to. Sending a blood culture at 48 hours was less complied to. Sending a blood culture, continuing 14 days of antibiotics, antifungals were more complied to. Doing a transthoracic or transesophageal echo was 50% compliance, and the total compliance of all the points was just less than 50%. And this is how you can see the different quarters in which the appropriateness and the mortality rates that you can see from this. So much so about the anti-fungal stewardship that we had. So just a word about also another, another particular stewardship program that we had was in the both for antifungal and antibacterial in the transplant unit, then the bone marrow transplant unit. So this was also led by the clinical pharmacy team. So, last year we had presented this in the Asia Pacific bone marrow transplant meeting. So we had compared with the retrospective cohort. And as you can see that after implementation of the antimicrobial stewardship, it showed a significant improvement in the 100-day survival compared to the early cohort. So now to conclude, I think what I would say is that in hematological malignancies and in patients with hematological malignancies and those undergoing oncologic treatments, you can have all spectrum of viral, bacterial, fungal, and parasitic infections, and prompt recognition, accurate diagnosis, and appropriate management of these infections are essential for optimizing patient outcomes. So multidisciplinary collaboration is vital for effective management. So we'll need infectious disease specialists working very closely with hematologists and oncologists we'll need a microbiology team who is alerting us, because the time is very important here. So even in the middle of the night, we would get microbiology alerts saying that, okay, you have grown, your patient has grown a candida, or so that rapid alert is very important. And also very importantly is the involvement of the other healthcare professionals, especially here the clinical pharmacist, which ensures a comprehensive and integrated care for the patients. So I cannot but stress the importance of very close communication and coordination among the different specialists, as we saw in the antifungal stewardship, which facilitate a timely decision making. And so that, the timely decision making is very important, especially for patients with neutropenia. So, and also, you have a tailored approaches. So, for example, what we had in a post-bone marrow transplant and severe neutropenic patients, we introduced, the antibiotic, sequencing, and also prophylaxis with quinolones. And we would look at the antibiograms every month, and then tailor our antibiotic use accordingly. And of course, it is also important that when we do, one of the things that we would generally do is to continue antibiotics forever. So the AMS actually taught us that, okay, you should reduce the unnecessary antibiotic exposure whenever possible. So, and also, when you actually do the antifungal and antiviral therapies, it should be based on specific pathogens. For example, if you have an aspergillus, you would rather go for a empiric treatment with voriconazole. And if you have a candidemia suspected, then we would rather go for echinocandins. So, and also the patient characteristics, of course, taking into account their renal functions and drug interactions, drug resistance patterns, etc., would be important in taking decisions in these cases. So I think some of these future directions are already there. The rapid diagnosis, as we talk, is already coming. You have the MALDI-TOF, you have the more robust availability of galactomannan now available. So we have the next generation sequencing available for many pathogens specifically. And so these all can aid in early identification and targeted treatment of the pathogens. So sometime in future, we would look forward to the point of care testing and novel biomarkers. And also, as we talk, we have emerging new antibiotics which are coming. And there are immunotherapies, which I have not mentioned. Some of the immunotherapies, especially for viral infections, would be adoptive T-cell therapy, and some other targeted therapies for some other infectious pathogens. Now, another strategy which is very overlooked in a hematology and oncology patients is vaccination. For example, currently now we have a influenza pandemic going on in the country, as at least in our place there's an epidemic going on. Sorry, it's not a pandemic. So, but what I realized is many of our patients we have not been able to vaccinate. So the influenza and pneumococcal are vaccines which we should optimize this strategy. So prevention is always better than cure. And and also other thing to stress is the infection control practices. Of course, strict adherence to the hand hygiene. So, isolation precautions and environmental cleaning, and that is also very important in a neutropenic host. And this is only possible if we have education and training programs for all the healthcare providers, including the doctors, paramedics, nursing. And of course, I think the most important people whom we should educate are the patients and their families. So I would always go to the patient side and tell them that, okay, use the hand rub, and ask everybody who comes and sees you to use their hand rub. So the patient is of course their best advocate. So these all can help to cut down the rates of infections in neutropenic hosts. So finally, I think at a larger level, a collaboration with the patient advocacy groups, can promote knowledge sharing and dissemination of best practices in infectious disease management. So I think with that, I would end here, and thank you for your attention.
Thank you very much, sir. That's a very excellent presentation. And you are showing the evidence like how AMS is helpful in the neutropenic and these patients. And we have some 2-3 questions for you, sir.
Yeah.
What is your preferred steroid in this hematology cancer patient? Like in the view of like immunosuppression, like drug interactions, what steroid you prefer for your patient?
What steroid?
Yes, sir. Yes, sir.
Okay.
Like
so
prednisolone or methylprednisolone or Dexacan. In the view of drug interaction and immunosuppression.
Okay, so I think the steroid choice is often dictated by the protocols that we use. For example, in a patient with who is undergoing induction for leukemia, it is usually prednisolone that we use. For the same patient who is undergoing a reinduction or at a later phase of acute lymphoblastic leukemia, it would be dexamethasone. So, and what we have seen is the susceptibility for infections is generally much more when we use dexamethasone as compared with prednisolone. That is one aspect. Second scenario where we use steroid will be in the post-transplant, post-bone marrow transplant, and the patient has a GVHD. So in that scenario, it would be methylprednisolone mostly. And the dose would be 1 milligram, the lower dose, probably 1 milligram per kg to 2 milligram per kg generally. Sometimes we would have to pulse also. Now in the post bone marrow transplant GVHD setting, the patients may have good counts. Okay, it may not be neutropenic. So in that setting, we see more of fungal infections. So whenever we give them methylprednisolone, it is we try to prophylax for mold infections with posaconazole. In ALL induction, generally we try to prophylax when you are on prednisolone. We try to prophylax for bacterial with cotrimoxazole and also fungal with fluconazole. When the neutrophils are very low, it would be less than 500. We would use fluconazole, fluoroquinolones.
Okay, sir. So, do you using any like posaconazole prophylaxis?
Yeah, so posaconazole, that's what I mentioned. So when the patient is neutropenic, okay, less than 500 ANC and expected to have ANC more than 7 days less than 500, posaconazole is the choice of prophylaxis for neutropenia. That's one instance. Okay. The second is, even if the ANC is more than 500, if the patient is a post-allogenic bone marrow transplant patient and the patient is on steroid due to GVHD, the patient will again be receiving prophylaxis with posaconazole.
Okay, sir. And the second question, like, what is your like dosing strategies in the patient on like azoles and as well as like calcineurin inhibitors? Like, you are doing any regular TDM or like directly you can decrease the dose?
Yeah, so we do TDMs for our calcineurin inhibitors and also for voriconazole. So any patient who is on voriconazole and calcineurin inhibitor, we generally go by the TDM.
Okay. And when you're implementing this MSP program, what are the barriers you faced? Like, what are the challenging and barriers? And how to involve the like families in the MSP program? Like, what's your experience and your barriers?
Yeah, it was a very nice experience. I mean, I would say it was a very learning experience for us because we thought, okay, we saw a lot of candidemia, and then a lot of people are dying, so we should do something about it. So we tried looking up the data. We found that, okay, these people are mostly in the ICUs, and we know, okay, this is the profile of this patient. Some of them may have candidurias before and all that. So, and we also realized that they are also in different departments. Okay, so I mean, nobody would want an interference. Nobody would want you to tell them, how to treat, right? So there was, and it was interesting that sometimes we would face, hey, why are you guys coming? So we had a set of few clinical pharmacy teams, pharmacist team who were very enthusiastic, and they would do. So they would go and write in the case sheet about the suggestion for a candidemia bundle. So initially nobody would look at it, but then they would call the department and say that we have, found this, and we would suggest this. They would actually go personally tell one of the doctors in the primary unit that, okay, why don't you do that? Why don't you do that? So it took some time. So as you can see, once you started the implementation, the initial cohort was till 2015, and the post-implementation cohort was from 2017. So the entire 2016, I think we worked on, how to get the clinicians and everybody listen to our team. So, but afterwards, it was, once we got the ball rolling, I think we didn't face much resistance. And very important thing was very good help from the microbiology team, because even at 2 a.m., 3 a.m. in the night, they would call up and saying that we have identified this pathogen. So that, really helped to cut down the, delay in initiating treatment. One of the most important things that we could do was to promptly initiate the antifungal treatment. And other thing that we could do was, many of the pre-implementation cohort, the dose was not correct. So we could actually get the right medicine at the right dose at the right time.
Okay. And like in the malignancy patient, like malignancy sometimes can also cause fever. Like if the patient and fevers, can we suspect always it is because of infection, sometimes because of malignancy? How can we differentiate it? As a clinical pharmacist, we are not expert in that area. Like as a hematologist, like when you think about it because of infection, when you think about it because of malignancy, those fevers.
Yeah, so I think that's a mix of some good clinical sense, and also a lot of caution is required. So for example, I think when you can look at the setting, right? So the setting is what I would tell our trainees is that if the patient is coming with you at the time of diagnosis and he has neutropenia, he or she has neutropenia, and he's looking well, and and then just having fever, one of the most important things is to look at the patient, and if the patient is absolutely well, no hemodynamic compromise, no tachypnea, so, and if you look at the markers also, sometimes you would see a low procalcitonin, but these are not absolute things. Okay, so you could have a patient who has an infection also, and at the time of presentation they may have fever due to the disease also. So for example, in AML, it is very difficult. You may have a disease fever and also have an infection. So now sometimes we have landed in trouble because we have started treating the malignancy, and suddenly the infection comes up. Especially the fungal infections, and until and unless we fall into that big pit, we didn't realize that our patient had such a fungal infection. So now what we do is, even at the beginning, before starting chemotherapy, we do the markers, the biomarkers, of course, the CRP and procalcitonin, and we sometimes do a screening CT of the chest and abdomen, and if clinical examination of a focus is very important. I think you have to actually look into the mouth, and you see sometimes it may be candidemia, candidal patches in the mouth is very, very suggestive, and a clear examination of the abdomen and chest, and of course in the perianal area, and the anal orifice, etc. So you have to actually strip and examine the patient very much in all aspects and see that there is no focus of infection there, and then combine that with your biomarkers of the CRP, procalcitonin, and sometimes add on as an imaging also. So if everything comes back as negative, then we may say that, okay, this is more likely to be a disease fever than infection.
Okay.
Viral is also difficult. Viral also may not have anything. So like CMV, you may not have anything in the imaging, everything may be negative. It may just be a CMV viremia. So, so for example, if it's a post-transplant, I wouldn't even stop there and I would still do the CMV titers before I declare that the patient is having disease fever.
Okay, sir. Okay, we are like done with questions, sir. Thank you, sir, like joining with us, and we hope we are like future sessions with you. And thank you, sir.
Thank you very much.
Yeah, thank you, sir. Hello, good evening, sir.
Good evening. Am I audible?
Yes, sir. Yes, sir. Our next speaker is Dr. Raju Suman, sir. Sir was a well-respected clinician in the ID and critical care community. And thank you, sir, for accepting our invitation and part of this event. And Dr. Suman is ID consultant, Jupiter Hospital, Pune, and honorary consultant at PD Hinduja Hospital. And sir was honored with fellowship of IDSA for his excellence, expertise, and contribution in the field of ID and patient care. Sir is a co-chair of Fungal Infections of Study Forum and a founding member and executive member of Clinical Infectious Disease of Society of India. And sir is a author of several chapter ID textbooks and a casebook of invasive fungal infections, casebook of HIV medicine, and editor of casebook of COVID-19. Sir also has like interest in antimicrobial PKPD and implementation is a regular practice. And thank you for sir joining with us. We are it's my privilege to welcome you on board. Over to you, sir. You can share your screen, sir.
Okay, good
Yes, sir,
evening,
actually.
friends. It's indeed a great pleasure to be discussing with you, and my thanks to Saidulu for this opportunity and all his other friends here. So HIV and clinical pharmacology is what I have titled this presentation. And I must tell you that there is really no other discipline in medicine in which clinical pharmacy and pharmacology is more relevant than in HIV medicine. And the reasons are many. For example, there are 40 different antiretroviral drugs, countless number of potential drug interactions. Now, how to use all these drugs, how to manage adverse effects, how to prevent and treat resistance, how to avoid interactions, and sometimes how to even benefit from some interactions. So these are the various challenges which we face. And the pharmacologist must also have a working knowledge of both infectious and non-infectious problems in HIV medicine. It's sometimes said that all drugs are poison, some have useful side effects. So let's see this first case. So this was a 42-year-old male patient. He was treated elsewhere, was detected to be HIV positive in 2000. He took stavudine, lamivudine, and efavirenz irregularly for almost 10 years. He had developed cerebral toxoplasmosis in 2014, and he had severe sulfa allergy, including Stevens-Johnson syndrome, when he was being treated for toxoplasmosis. After that, he didn't improve really remarkably, and he was on some irregular treatment with pyrimethamine, clindamycin, folinic acid. His treatment had been changed to tenofovir disoproxil fumarate, that is TDF, 3TC, and boosted atazanavir, and later on it was changed to abacavir, 3TC, and boosted atazanavir. All this was going on till 2015. When he developed unsteady gait, mood changes, and then he stopped his treatment completely. At that stage, he was referred for an ID opinion. That was in 2015, 4 weeks later. So he kept on having skin rashes, as you saw in this previous picture, almost all the time. His MRI was done. We showed that there is still some lesion which is seen there like a ring enhancing lesion. So neutropenia was also found. And If you notice here in this MRI plate, the second one, you see diffuse white matter changes, which are bilateral in the periventricular gray and white matter. His viral load was very high, CD4 count was very low, as you can see. He was asked for his resistance test, but he gave the sample only after another 1 month. That was almost 7-8 weeks after having stopped his treatment. And he came back with this report in which a subtype C was found and no resistance was found. Lots of mutations, but most of them are polymorphisms. So what can be used as treatment in 2015? That is the question which we were facing at that time. And none of these would probably be best for him. And we'll see the reasons why those are not too good. So how do we consider treating this patient? The patient has neutropenia, probably because of pyrimethamine. But we also know that pyrimethamine is needed because he's still having this toxoplasmosis. So he has partially treated toxoplasmosis. So we do need pyrimethamine. We need an effective and well-tolerated regimen. He has sulfur allergy, and therefore we want to avoid sulfadiazine as well as darunavir, because remember, darunavir also has a sulfur moiety in it. He probably has resistant HIV, although this resistance test does not show it because it was done 10 weeks after stopping therapy. So on the basis of his history, which he gave us, he must be having an NRTI, NRTI, and some PI resistance, which is on the basis of the history. So it's very important not just to look at the resistance test, but also go over every element of his previous treatment. And he probably has HIV-associated neurological disorder or neurocognitive dysfunction. And therefore, we probably need CNS-targeted ART. Okay, so if you look at all this, these were the options which we were discussing. So zidovudine will probably not work because of the likely thymidine-associated mutations. It was also avoided because of his neutropenia and the continued need for pyrimethamine. So the additive toxicity might produce too much of neutropenia. Darunavir, as I said, was to be avoided in view of his severe sulfur allergy. Tenofovir may not work in this situation because of the likelihood of TAMPs being there, and many TAMPs may be there. By you might be knowing that if there are more than 3 TAMPs, tenofovir generally doesn't work. Now, raltegravir was available at that time, but that may not work as the NRTI backbone is weak. So the genetic barrier to resistance of raltegravir is not strong. And therefore, it will work only if the rest of the regimen is strong. This regimen may work, but has less CNS penetration efficacy. So let's look at something else. So on one hand, we wanted to optimize his treatment for cerebral toxoplasmosis. So that was optimized by using pyrimethamine, a very high dose of folinic acid, like 90 milligrams, and azithromycin instead of steroids, instead of sulfadiazine. And what can be considered for use would be boosted lopinavir, raltegravir, lamivudine, and maraviroc. So for use of maraviroc, we need to see a co-tropism assay. So in this, it was found that this particular virus was a CCR5 using virus, and therefore the antagonist like maraviroc might work for this situation. So maraviroc was added both for enhanced efficacy as well as CNS penetration efficacy. So for a patient on a failing regimen like this with very limited options, the selection will be on the basis of some extrapolation rather than based on randomized controlled trial data. As there is no control group possible here, only follow-up of such patients can point to what may be used in future patients. So this regimen worked very well for him. His viral load declined, and finally at 1 year it was even undetectable, and the CD4 count went up. The next case is a lady with fever and weight loss detected to be HIV positive again way back in 2012. Her CD4 was low, viral load was high. She was started on zidovudine, 3-TC, and efavirenz elsewhere, and really achieved and maintained complete viral suppression. She also had type 2 diabetes, and she was on oral hypoglycemic agents. Now, 5 years later, she developed all these features, was found to have HCV with very high viral load, genotype was 1, and HCV treatment was planned by the hepatologist with sofosbuvir, and ledipasvir, which were the recommended treatment, that time in 2017, along with ribavirin. Now, her ART was therefore changed to TDF FTC efavirenz. Why? In view of anemia, anticipation of additive myelotoxicity with ribavirin, and ribavirin may compete for thymidine kinase for bioactivation of zidovudine. So therefore, you don't want to use zidovudine in this situation. Besides, there can be an interaction between sofosbuvir and ledipasvir and TDF, and therefore that toxicity could be occurring, and therefore a close monitoring for TDF toxicity was advised. The patient was admitted 1 month later with nausea, anorexia, reduced urine output, tachycardia, tachypnea, severe pallor. As you can see, there is a urine which shows 2+ proteinuria, 4+ blood, and the creatinine has gone up very high, like 4.5, 5. So what could be the cause of a nephropathy? Could it be HIVAN or HIV-associated nephropathy, or HIV-associated immune-mediated nephropathy, or thrombotic microangiopathy, or TDF-induced nephropathy? And we'll have to look at all of them in detail. So HIV-associated nephropathy is much more common in African Americans. It has a particular type of histology, and there are many features which are there in this patient which cannot be explained by this. On the other hand, HIV-associated immune-mediated nephropathy is likely to be the correct diagnosis. So this was subnephrotic proteinuria, 2+ proteinuria. There was an active urine sediment. You saw 4+ RBCs. And co-infection with HCV will make this immune-mediated HIV nephropathy as the most likely possibility. Thrombotic microangiopathy also seems to be incorrect. It is often associated with anuria or oliguria, hypertension, and other features. TDF-induced nephropathy, again a strong contender in our mind, but that also seems to be incorrect. It can occur within a few months, but usually, again, it is non-oliguric, and it shows RTA-like features, that is renal tubular acidosis-like features with glycosuria, aminoaciduria, hypophosphatemia, and so on. Yes, this interaction may result in a higher level of TDF because of P-glycoprotein efflux transporter, and that can account for toxicity. However, this acute presentation with a very active urinary sediment within a month of starting TDF does not fit with the usual type of TDF-associated nephropathy. So therefore, this was thought to be HIV-associated immune-mediated nephropathy, and therefore, steroids were to be started. Optimization of PI and DTG-based therapy was planned for later. So right now, TDF as was discontinued, and only boosted atazanavir and lamivudine was continued. The biopsy confirmed that this was immune-mediated nephropathy, and glucocorticoids were given. Now, she developed uncontrolled diabetes despite increasing the doses of insulin, and she was admitted with findings of rhino-orbital mucormycosis. So liposomal amphotericin B was started for this patient. And as you can see, it grew this, which was identified as Rhizopus erizus. So mucormycosis is a common OI in AIDS patients, or mucormycosis is strongly associated with diabetes in India. The management of mucormycosis is quite different in HIV-infected patients, or all of the above are true. And the answer is that it is strongly associated with diabetes, but the rest of them is not true. So it is not an important opportunistic infection in AIDS patients, but it is very strongly associated with diabetes, especially in India. The management is not very much different. Mucormycosis needs to be treated almost along standard lines, as there are few alternative drugs available. So you need to continue the drugs of choice for mucormycosis and make suitable changes to the HIV regimen. That is going to be more important in this situation. So optimization was done in that in 2017. An alternative could have been to use DTG-3TC, which should be effective at least temporarily based on the trial called as a Downing trial. And the optimization of adding a boosted PI could be done after completing posaconazole therapy, because as you know, there is a lot of interaction between atazanavir or any other boosted protease inhibitor with posaconazole. So atazanavir increases the posaconazole by almost 1.5 times and needs dose reduction, but posaconazole increases the level of atazanavir mildly. So there is this interaction which is important. If you look at it today, probably you don't need the boosted PI, and only a two-drug therapy with DTG-3TC can be an option today in 2023. And that is because of certain electronic and molecular architecture properties of DTG. So DTG has a very prolonged binding and a very tight binding to the integrase, and that is because of certain parts of the molecule. And therefore, it can work very well only with one other drug such as 3TC. Okay, so dual therapy is a concept which is now emerging because we have this kind of a second generation INSTI. So the messages from this case are adverse drug reactions and other problems in the patient need to be sorted out very carefully. Attention to drug-drug interactions is always necessary. Some infections like mucormycosis have only few options, and ART has to accommodate the drug which we are going to use for mucormycosis. Now, new data has shown that boosted PI is often not necessary, and DTG plus 2 NRTI or even DTG plus only 3TC can be effective even in the presence of previous failures and baseline resistance. Now, interestingly, this can avoid toxicity, pill burden, potential interactions, as well as expense. Let's move to this case. So this is a elderly gentleman, 79-year-old, HIV positive on zidovudine, 3TC and efavirenz for the last 10 years. He had TB bronchiectasis in the past. He had supraventricular tachycardia as well as hypertension on diltiazem, and he was admitted elsewhere in a gasping state. So he was intubated, ventilated. There were repeated episodes of atrial fibrillation despite the amiodarone. Acinetobacter was found in his ET secretions. He was started on all these antibiotics. There was a question whether there is PCP, and therefore the patient was referred for an ID opinion. Now, overall, it looked like that the patient was having CNS dysfunction, deeply unconscious, low urine output, creatinine had risen rapidly. SGOT, SGPT had also gone up rapidly. His ejection fraction was found to be very low, but his CD4 count was relatively good, 550, but that was 1 year ago, and they had not done a viral load. The patient on history was adherent to his ART, but he was not on TMP SMX, again raising the remote possibility of PCP. His ET secretions as well as the blood culture had flagged positive, and therefore the ID reference was there. So what from the following seems to be most likely in this patient? And interestingly, it is a non-infectious problem which seems to be the most likely, and we will discuss each one of them. So there are some points in favor of PCP, but the points against are much more. The patient is seriously ill, his past CD4 was relatively good, and he was adherent to ART. And therefore, although there was some ground glassing, it does not follow the particular pattern which we see in PCP. Bacterial pneumonia, Acinetobacter was found from his tracheal aspirate, but the positive predictive value is poor. There was no actual infiltrate pattern looking like a bacterial consolidation. Sepsis syndrome, the patient had shock, multi-organ dysfunction, blood culture had also flagged positive, but we really need to know what is the sample which flagged positive. And there was no fever or leukocytosis. On the other hand, the patient had LV dysfunction, he had recurrent atrial fibrillation. All this could be explained on the basis of a shock liver where the enzymes went up, the renal, pre-renal azotemia developed, hypoxic brain damage developed, and that probably is the best explanation for his clinical picture. The tracheal aspirate culture again showed Acinetobacter, and there were two bugs found in his right internal jugular vein, and that was Klebsiella and Enterococcus. But these were found only from the internal jugular vein. The peripheral cultures were negative. Similarly, the pneumocystis from the atrial endotracheal secretions was negative. The galactomannan was also negative, and he had very poor LV dysfunction. So now with supportive treatment, he became better. His creatinine reduced to 1.5, hepatic and cerebral function normalized, His viral load, which had not been done recently, was found to be very low. So that was less undetectable, less than 40. So what do we think are the options about his ART? How would we choose them? And obviously, we don't want to give boosted PI. We don't want to give him efavirenz, although he is very well controlled HIV-wise. And what are the reasons? So renal dose modification is needed. Agents without cardiotoxicity, nephrotoxicity, and interactions are needed. Abacavir only after knowing the HLA-B5701 status. And we also probably need to know his pre-treatment viral load. So why don't we want the boosted PI-based ART? Because that increases the risk of amiodarone toxicity. Remember, he has recurrent atrial fibrillation and SVT or supraventricular tachycardia, and so he does need the amiodarone. Efavirenz-based ART, efavirenz leads to low levels of amiodarone. And this perhaps may be the reason why he was having refractory SVT, because he was already on efavirenz and somebody was trying to give him amiodarone. So DTG-based ART will probably be the best, which will have no interactions with amiodarone. There was also a possibility of zidovudine-induced cardiomyopathy in this elderly patient, and therefore we probably did not want to continue zidovudine. So in this elderly patient who's now just recovered from renal dysfunction, tenofovir alafenamide rather than desproxil fumarate would be the better drug to use in this situation in view of less nephrotoxicity, age, and also less bone toxicity. So this case really tells us how we would choose drugs in this complex situation. So we were happy with this. So TAF, FTC, DTG was started. The patient developed a lot of sleep disturbance. Now, what could that be due to? Now, age-related alterations do occur in DTG efflux transporters. And you are aware about P-glycoprotein as well as the breast cancer related protein. So these lead to higher Cmax of DTG. So if you look at patients above the age of 60, they can have very high levels of dolutegravir, which may lead to sleep disturbances. And therefore, it may be better to dose it in the morning. And then there was no decline in not associated with sleep disturbances. So the messages from this case are we have to critically analyze data to differentiate non-infectious from infectious causes and colonization versus invasion. And I've particularly chosen this case for discussion because many of you are interested in stewardship as well as trying to differentiate an actual infection from colonization. We want to consider drug interactions and decide how to manage them. We also consider evolving new drug strategies as evidence accumulates and they become more established. And the example here is a DTG with 2 NRTIs or DTG with a single NRTI such as 3TC. We need to consider actual and potential adverse drug reactions, even if some of them are really uncommon and found only in post-marketing surveys. So this DTG producing sleep disturbances is a rather uncommon adverse effect, but can occur in elderly patients, which is something to keep in mind. And the elderly are as a group are definitely those where further caution is needed when we are using drugs. So I'll close by saying that management of HIV infection has become dramatically more successful, but it nevertheless remains still very complex. The current idea is the tendency to avoid pharmacological boosting. Okay, so we are using less and less of boosted PIs. We don't even have cobicistat in our country. So the use of ritonavir as pharmacological boosters is definitely going down, and thanks to the new generation INSTI, which has made all this possible. So although the second generation INSTI or integrase in strand transfer inhibitors has mitigated some of these problems, other problems do remain. So selecting appropriate medications to suit the patient from so many which are available, contending with resistance, adverse reactions, as well as interactions, it still continues to be a balancing act. And with this, I will stop here. And if there are any questions, we can discuss them. Thank you.
Thank you, sir, for presentation. So we have 2-3 questions for you, sir.
Yes.
So what are the best available resources for freely available resources for checking drug interaction for especially HIV drugs?
Yeah, that Liverpool drug interaction is checker is there, but otherwise
Oh.
even Medscape is there. Then I think DHHS, that is Department of Health and Human Services from USA, in their guidelines also they have good interactions. The most relevant ones are definitely there, but if you want more details, then Liverpool and Stanford also has a drug interaction checker. So these are some of them. You could follow any one of them.
Oh, thanks. The next question regarding sulfur drug allergy, like there is a concern that any molecule contains sulfur, most of the clinicians they avoid the sulfur. Actually, it is because of sulfur, because of sulfonamide. What is sulfonamide drug allergy actually? If any medication contains sulfur, we can
That
avoid
is
the.
that is true, but yeah, it is recommended even with darunavir to not to be used in patients with sulfur allergy.
Okay.
So that's why we didn't use in this particular patient. And the patient, even without his sulfur drug, was still having rashes and some problem all the time. And as a clinician, I would definitely not like to use anything which is even remotely likely to produce SJS. SJS can be a very fatal disease. To
Yes, sir,
manage
still
that is very, very
no
difficult. Yes. So I just don't want to take a chance. Maybe there is some alternative drug which we can use and not try to use this re-challenge and all that. Although in pharmacy literature, it might be told that you can possibly re-challenge. I will not do it.
Okay. And like the patient in ICU, there is a known case of RVD positive. What is the current strategies like management of ICU patient with HIV?
See, if the current treatment, like as I
When to
said,
start
that
ART? When to start ART?
no, what
When to
is your
stop
exact
ART?
question?
The patient ICU with HIV positive, like patient already with some patients using ART. So when to start, we stop ART, or when to start new ART medication, or when can we hold the ART
So,
medication?
okay, so if the patient is already on antiretroviral therapy, it is advisable to continue that as far as possible. Now, if it happens, now these questions, are no longer so relevant in the age that we are in currently. In the past, that
Okay.
was a very, very important question because we had NNRTI based regimen as well as boosted PI. Now, both these used to have lots of interactions. Similarly, if there was zidovudine, there used to be additive myelotoxicity with many other drugs. If there was tenofovir, again, there used to be a problem with renal dysfunction and so on. So today, if somebody is on dolutegravir based treatment, which will have very little interactions, the main interaction is only with metformin, which we don't even use in the ICU. Okay, so and with certain anti-arrhythmics and anti-epileptic drugs, these are the only 3-4 important interactions of dolutegravir. So none of these need to be specifically used in the ICU patient. So if the patient is on dolutegravir based treatment with 2 NRTIs, and if there is an issue of a renal dysfunction, you can safely remove the tenofovir and just adjust the dose of lamivudine, which also needs very little dose adjustment, only at very low levels of renal EGFR. Otherwise, the dose adjustment is also comparatively easy. Now, both these drugs are just small tablets. You can give them through the rice tube. They are not available intravenous. So that is an issue. So you
Yes,
can
sure.
continue this treatment. So even if other treatment is there and you find that there is a problem of continuing the other type of treatment, then we can switch to dolutegravir with 2 NRTIs in most of the patients. If the patient is admitted for a serious problem and you are going to initiate the ART at that time, then it depends upon what sort of problem is there and how bad is the CD4 count or viral load, and whether the patient is sick because of a acute myocardial infarction or some stroke, which definitely becomes the important thing, and there is no urgency of starting ART in this particular patient. Then it is okay. You can wait for some time and then start the treatment. Now, if it is a setting of an opportunistic infection such as TB toxoplasma, cryptococcal meningitis, there are definite guidelines. It's a very big topic. I don't think I can quickly answer that question. But importantly, there is a push for starting ART as soon as possible, even in many of these settings. Although I don't personally agree with each and every recommendation which has been made, but it is very important not to start ART soon in cases where there is CNS involvement in the form of tuberculous meningitis, or sometimes tuberculomas in the brainstem or in the cerebellar area where raised ICP can become a major problem, or in the setting of cryptococcal meningitis. So in these three situations, we do not like to start the ART very soon. In other situations, in toxoplasma and all that, we can start. But I don't personally think that there is a great hurry of starting. That means you have to start it on the same day or next day or something. I don't think it is so important. And similarly, I don't think it is so important even in the setting of PCP. So let the patient be better, take at least 15 to 20 days of treatment, and after that one can start this. Because you can even get a iris-like situation in PCP,
Yes, sir.
even without ART. Okay, so we already know that patients who have desaturation do require a large dose of steroids. So it is very reasonable not to start ART in such a patient who's got severe PCP immediately. Till we wait for 15 to 20 days till the treatment is nearly over, and maybe at that stage one can start.
Thank you. So the patient is post-transplant is on posaconazole prophylaxis, and he's receiving calcineurin inhibitors, and he's diagnosed with TB. So he's on posaconazole and calcineurin inhibitor and rifamycin. Like in these situations, like posaconazole is the CYP inhibitor, and rifamycin is the CYP inducer. So both can act on the calcineurin inhibitors. Like how can you manage this kind of complex situations in the real-time settings? So can we stop rifamycin or can we?
Yes, absolutely. See, I think Parikshit briefly talked about such a case where
Yes, sir.
there was a question of TB in a patient who already had aspergillosis or something else. So first of
Yes,
all,
sir.
sometimes TB is made, diagnosis is made on the basis of a BAL sample, and where only a trace has been found. Okay, so one will still need a lot of clinical judgment to really see whether this is just a contaminated sample from the bronchoscope. Because if you look at the CEPHID literature, the company has not validated a BAL sample for using an expert. So we are actually using it off-label. Okay, so rarely the bronchoscope can get contaminated with molecular contamination can happen. So we have to be very sure whether first of all TB is there. Now, if TB is there, is it a major involvement such as say TB meningitis or miliary or something like that? So how important is that TB, or it is a small focus of TB, in which case a non-rifampin based treatment can be used. So in this situation, if you have a DST or if you have pyrosequencing, which tells you that other drugs are also effective, then definitely you can avoid the use of rifampin. That will simplify matters quite a bit. Now, if the patient is on posaconazole and also needs a tacrolimus or a CNI, then generally 50% reduction of the CNI is what is advised, but it is subject to the results of TDM. So you don't definitely need to do TDM for the calcineurin inhibitor as well as for the posaconazole. And the rule of thumb is reduce it by roughly 50%.
Okay, sir. And any suggestions for ID clinical pharmacist in India?
That they should attend rounds, as I think majority of you are doing. They should definitely attend the rounds and be involved. And I am very happy that even in Jupiter we have a very good ID pharmacist who is interested in ID. And so I think they can take it forward. I'm going to send him to you for further training and also doing AMSP.
Okay, thank you.
He's already made a beginning, and I think that is That is the suggestion, that come on the rounds every day and get involved, because see, the whole clinical picture is also very, very complex. It's not
Yes,
just
sir.
the drugs. You need to understand microbiology. You also understand the clinical medicine. So sometimes
Okay, sir.
we jokingly call ourselves ID physicians as jack of all trades, and we are masters of none. So we need to understand pharmacology, microbiology, clinical medicine, radiology, and everything. So same way, the pharmacist should also try and understand some of these things, because no use just hankering after some minor interactions. You have to see in this patient how certain are we about each diagnosis, and in the example that I gave you, how important it
Yes,
is for
sir.
that patient's or for the fungal infection. Which one is more important? So for aspergillus, we definitely know that liposomal or other amphotericin B preparations is 15-20% inferior to the azole. So you can't say that I want to treat this aspergillus with amphotericin B. You are giving a much more expensive and less effective drug, and because you want a refamily.
Okay.
Okay, so that probably is not a good idea to do. Okay, so these kind of decisions can definitely be taken at the bedside when you assess the patient as a whole.
Okay. So thank you very much, sir. Sharing your experience with us. It's our honor to be with us. We are hoping future session with you. Thank you, sir.
Thank you.
Bye, sir. We requested to participants. We'll send you the feedback form. Just please fill that feedback form. You can receive the certificate within 10 days. And we have a session tomorrow on TDM. We have also 3 speakers. It will start at 5 o'clock tomorrow. And please attend the tomorrow session. Thank you.